Welcome to the JMIRO Publications Workshop for 2023. This one is on how to use numbers in your publication. I'm Michael Barton, I'm the Editor-in-Chief of JMIRO and the person that seems to put how to twice in their title. However, this publication workshop is called How to Use Numbers in Your Publication because we didn't want to use the word statistics right at the start. The key learning points, however, are how to use statistical guidelines to improve your publication, understanding the common misconceptions about the presentation of data and how to avoid them, to learn when to use tables and graphs, learn where to report your data in your paper, and discover novel visualizations for multidimensional data. The presentation of your data is the most important piece of communication in a scientific paper and the one that receives the most scrutiny. And just to quote R.A. Fisher, who's famous for a number of contributions to statistical tests that you'll come across, to consult a statistician after an experiment is finished is often merely to ask him to conduct a post-mortem. You can perhaps say what the experiment died of. So we don't want that to happen to your papers, and we have assembled a cast of statistical experts, two of whom are editors on JMIRO, to talk about a range of topics that we hope will help improve your publications. Unfortunately, as you'll see, Tim Church's, you'll see his name scratched out there on the timetable for today. He's had a medical emergency. Fortunately, he's fine, but he's unable to attend, and we will add his presentation to the webinar when it's put on the college webpage. You can find the previous JMIRO webinars on the college webpage, and you can also find this one in a couple of days once we've added Tim's contribution. So I'd like to acknowledge the Gadigal people of the Eora Nation, the traditional custodians of the land on which this video conference is hosted. I'd also like to acknowledge the traditional custodians of the lands where my Australian-based colleagues are located today and pay my respects to their elders past, present and future, for they hold the memories, traditions, cultures and hopes of the Aboriginal and Torres Strait Islanders, peoples of Australia. In recognition that we are a bi-national college, I take this opportunity to acknowledge Māori as the Tongawetha, I'm sorry, terribly mispronounced that, Whenua and Treaty of Waitangi partners in Aotearoa, New Zealand. We will have a live Q&A session at the end of this webinar. Please submit your questions in the questions panel in your control panel on the right of the screen. Our first presenter is Professor, and the last thing I wanted to say is that if you want to get any further reading, this is an excellent book that's just been published on the art of statistics by David Spiegelhalter. He's a renowned Bayesian statistician, but don't let that frighten you off. And he covers the entire gamut of statistical examinations in a very approachable and engaging way. So, as I said, our first speaker is Professor Paul Parizol. Fortunately or unfortunately, Paul can't be with us. Unfortunately, he can't be with us, but fortunately, he is in Europe attending the birth of his grandchild. Paul is the chair of the Radiology Research Committee. He is the inaugural David Hartley Chair of Radiology at the Royal Perth Hospital and the University of Western Australia. He has a part-time appointment at the Royal Perth. He also serves as the director of the West Australian National Imaging Facility, NODE, and he is a well sought after speaker with more than 500 invited lectures at international meetings under his belt. He will be talking on the topic of radiologists and numbers. This is, as I said, a pre-recorded talk. You may find the volume is a little low. If so, please turn it up on your speaker. Thank you. So
Greetings from Perth, Western Australia. It's a great pleasure to join you for the JMIRO Publications Workshop, organized by the editorial board and by our editor-in-chief. I'm grateful to Professor Michael Barton for the kind invitation. It's a pleasure and an honor to be here and to talk to you on how to use numbers in your publication. My name is Paul Perizel. I'm the David Hartley Chair of Radiology at Royal Perth Hospital and the University of Western Australia, and we're going to be looking into numbers. I do have some disclosures, but whenever I'm showing information from the industry, I will clearly indicate so on the slides I'm using. This is the outline of what we are going to be talking about. Explain why radiologists don't like numbers, give you some tips on how to report numbers, and talk about big data. Now, radiologists don't like numbers, and you may be familiar with the old saying that a radiologist looking for a ruler is a radiologist in trouble. About 20 years ago, Gary Miller of the Mayo Clinic lamented that in the United States, they continue to train residents and fellows in the tradition of training eyes to identify and characterize abnormalities without the need for a ruler. The same thing is basically true in the United Kingdom, where Paul McCoubrey coined the so-called rules of radiology. And in the 2013 edition, we find such pearls of wisdom as rule number 11, never measure anything, and rule number 12, never count anything. Fortunately, these rules have been discarded in later editions. So why is that? Why do radiologists do not like to measure things, do not like to bring numbers in their reports? And it's probably because the radiological 2D interpretation of a 3D reality is somewhat similar to the flat Earth theory. And for far too long, radiologists have been what I would call flat earthers. Now, in the days of conventional X-ray, that was fairly easy to understand. As an example, I show you the so-called Pavlov-Torg ratio that we had to learn many years ago to identify the diameter of the cervical spinal canal. And by simply measuring distances of the AP diameter of a vertebral body and the diameter between the posterior wall of that vertebral body and the spinous process, without taking into account the other diameters of the spinal canal, the width, the neural foramina, the lateral recesses, the soft tissues, the ligaments, the intervertebral discs, all of that didn't count. So you can understand why radiologists were somewhat skeptic about this. Now, when you consider a projectional radiograph, that is inherently flawed. The representation of a 3D object in a 2D image plane causes many errors and may lead to erroneous interpretations, as illustrated in this simple example of a staircase, or a more artistic rendering of this cylinder that, depending on how you project the 3D object on a flat plane, can look like a cube or a circle. And that is very much in the eye of the beholder and indicates the flaws of measuring. Now, it's hard to understand why radiologists would continue to use 2D images when 3D is readily available. Many radiologists here in Australia don't like 3D. They frantically scroll up and down a data set trying to identify something rather than reverting to the 3D image. And we are sometimes told that 3D images are only good for clinicians and radiologists who don't know their business. And it's kind of a sad state of affairs to consider that the technology in a present-day video game is by far surpassing what we are using in medicine. At the University of Antwerp, where I previously worked, all of our workstations had access to the AW suite, and we were looking at all our cross-sectional data sets, be they CT or MR, in a 3D viewer. There was nobody who was looking at 2D images and scrolling up and down the data. Second point, how to report numbers when you finally get them. Well, using numbers in scientific manuscripts, don't start a sentence with a numeral, use spelled out numbers at the beginning of a sentence. Be consistent in the use of numerals and spelled out numbers. Use words for small numbers, 1, 2, 3, 4, etc., and numerals for large numbers, generally over 10. Be consistent in your formatting. When using thousand separators, always use them in the same way, either no space or a comma, but only use one format in the text. And similarly, do not mix the use of a decimal point with a decimal comma. Check the journal to which you are submitting your paper and confirm with the guidelines. Read the author guidelines carefully and apply them rigorously. And you will find examples in radiology or JMIRO. And for example, when you write in the materials and methods section of a study with a patient cohort, you will need to indicate the number of patients, the sex, the mean age, the standard deviation, the median age, the interquartile range, and for the study. And if you're, for example, dealing with 100 patients, 60 men, 40 women, then you should write 100 patients with a mean age of 47 plus minus 10, 60 men, so you provide the sex of the larger number of patients. You need to indicate p-values corresponding with comparison values. You need to include confidence intervals when appropriate, and you need to use the SI, Système International, or SI-derived units as units of measurement. Accuracy and precision are important concepts that any radiologist should understand. They are different, but should be considered together. Accuracy indicates how far from the target you are, and that is basically the bias of your technique. On the other hand, precision, often referred to as repeatability or reproducibility, indicates how narrow the bell curve is, so how good your measurements are clustered together relative to the average value that you want to measure. There's a few more concepts to keep in mind when dealing with numbers. Uncertainty of measurement is dealt with by providing confidence levels, usually 95%. You need to be aware of voxel sizes of imaging, which is the size of the smallest information. Contrast or density resolution in CT is the ability to discern objects of low contrast or density relative to homogeneous surroundings. Spatial resolution is the property to recognize objects lying close to each other as separated from their surroundings. And structural resolution is the smallest structure that can still be measured dimensionally. An important error that I often see is that radiological journals have no indication of absolute, relative, and percent error. An absolute error is the true value minus the measured value. A relative error is the absolute error divided by the true value. If you measure an object that is a tumor, for example, that is 12 centimeters in diameter, and you have an error of 3 millimeters, that is your absolute error. But the relative error is the 3 millimeters relative to the 12 centimeters. So your measurement is actually pretty good. You can also express that as a percent error. Numbers should be, and often are, graphically displayed in several ways. For example, with box plots or scatter plots. And the box plot on the left gives you the 25 and 75 percentiles with the median. And there are on top and bottom so-called whiskers that indicate the range of the measurement, and that would allow to separate out two populations. Another way of doing that is with a scatter plot, where you use different symbols or different colors for different populations, and you can draw kind of trend lines from these populations as illustrated on the right side. Try not to get lost in statistics. I like this quote by Mark Twain that there are three kinds of lies. There are lies, damned lies, and statistics, and that holds true for a lot of radiology. And unfortunately, many radiologists get lost in that domain. Number three, images are big data. I'm sure that many of you have seen this, what I would call a landmark paper published in Radiology on radiomics. Images are more than pictures, they are data, published by the group of Hedwig Riechak from New York. And the way to actually mine these data is through image segmentation, which holds the key to quantification. In this example, we are looking at one data set, which we can segment out for cerebrospinal fluid in red, gray matter in green, white matter in yellow, or whole brain in grayscale. When we apply that in a patient with multiple sclerosis, for example, we can segment out the white matter lesions and we can segment out the gray matter. We feed that in a computer and we get lesion segmentation and tissue segmentation. And we can then compare that between a previous study and a present study and evaluate the FLAIR white matter hyperintensities. Mind you, these are 3D FLAIR sequences, isotropic, able to reformat in any given plane and give you an idea of the total lesion load within the brain of this patient with multiple sclerosis. Now, the neurologist who is referring that patient is not interested in getting a report saying that there are multiple white matter lesions. They know that. That's why they send the patient. What they want to know is whether there are new, enlarging, or stable lesions, and they would like to see that in a parametric report of the MRI scan. At the University of Antwerp, we started doing that about 7 years ago in 2016, comparing lesion volumes at different time points. And this is the report that we would give to radiologists, to neurologists in patients with multiple sclerosis, showing the volume of lesions on the current scan, comparing that with the previous scan and the previous scan, and doing that in different anatomic regions as identified by the McDonald criteria, the periventricular, juxtacortical, infradentorial, and deep white matter. Another example of applying these quantitative techniques is to assess midline shift on axial scans, which is notoriously inaccurate. If you give the same data set and you ask 5 radiologists to measure the midline shift, you are likely to get 7 different opinions because they will measure this on different images, on coronal images or whatever. There's software available for this that we were using in Europe, which is called the Traumatic Brain Injury Report, which gives you a very accurate representation of the midline shift. And it always uses the same technology. So your present scan is perfectly comparable with the scan that you were doing 2 days ago or 3 days ago or whatever, because you use the same measurement technology on the same slice according to the same parameters. My final thoughts on numbers in radiology. Well, this is a somewhat philosophical statement, but I would say that clinical radiologists, I'm one of them myself, with instinctive aversion to numbers, are basically 2D imaging experts who are at risk of being left behind in a rapidly evolving 3D digital world. in imaging studies, and especially for follow-up scans, which are now the bread and butter in oncology imaging, reproducibility, which is the cornerstone of all science, is more important than the absolute truth or accuracy, which is an epistemologically debatable notion to begin with. It's more important to measure something every single time in the same way with a software than having measurements that are done by different people based on different technology, based on different images. And that is important to understand. In the imaging pathway, we theoretically want our imaging to be accurate, sensitive and specific, validated, objective, unbiased, and precise. And that pathway consists of image acquisition, image contrast setting, sequence, size, thickness, pitch, whatever, image processing, and image interpretation. And unfortunately, in the radiology workflow, all of these elements are subject to variations because of different vendors, different sequences, different protocols, different software, different variable interpretations. So the way forward is standardization. And if radiology is going to survive, diagnostic radiology is going to survive as a discipline, it will need standardization in all of these aspects. So looking into the future, we come from a time when blood tests were done manually and were subject to subjective interpretation. But since many years, when you draw peripheral blood and put it in a centrifuge, the requesting physician gets a report with numbers. Numbers indicating the number of red and white cells and thrombocytes and the liver enzymes and the glucose and what have you. Well, I think that the time has come that we need to think about doing something similar with the imaging lab, where you start with a data set, be it MR or CT, or perhaps even ultrasound, and you process the images, you acquire, you process the images and interpret the images in exactly the same way so that you can provide numbers to your clinician and that your clinician has independent information on which to act. So the 21st century to-do list for radiologists will be to ensure the quality and reproducibility of the imaging studies. That also means that we need to calibrate our instruments. That's a radiological responsibility. We need to standardize the production chain, starting with all aspects of that production chain, including scheduling, acquisition, processing, interpretation, communication, integration. We should embrace quantitative imaging. That is the way to the future. We should understand that imaging has essentially become a big data science. It's not about pretty pictures, it's about big data. And the only way to survive in this world is through artificial intelligence, which is the way forward to dealing with big data sets and the way forward to producing structured reports that give accurate numbers to clinicians. Thank you very much for giving me the opportunity to share these few thoughts with you. And I wish you a successful workshop. Thank you very, very much.
Well, that was a very thoughtful presentation that has really set the scene for us today. Our next speaker is Mr. Matthias Brethel. He'll be talking on statistical myths and legends and how guidelines can help. Matthias is a senior statistician at the Centre for Biostats and Clinical Trials at the Peter MacCallum Cancer Centre. Matthias has over 20 years of experience with biostatistics and clinical research, working exclusively with oncology since 2010. Feedback, could we mute? Yep. And he has been the clinical trial statistician on many radiation oncology and imaging trials for Peter Mac and for TROG, and collaborates on a large number of retrospective studies as well. Most importantly, Matthias is one of the statistical reviewers for JMIRO, and he helps us maintain a high quality of scientific publication. So over to you, Matthias. Thank you.
Thank you for the introduction. So today I'll be presenting to you some statistical myths and misconceptions. There are a number of them, and they exist for a few decades. And from time to time, statisticians write some papers trying to bring that to attentions to other researchers. More recently, at the end of last year, in December, the statistical editors of the BMJ wrote this paper describing 12 statistical issues in a very, very jolly way, in which they even included song for you if you want to rehearse for your next Christmas party. So just describing some of the issues. And sometimes one statistical concept might have many myths associated with. We have this excellent example from the paper from Stephen Sen, in which he describes 7 myths of randomization in clinical trials. With so many myths in a part of our jobs, we deal with those very frequently, either when we are assisting researchers with their research, or when we are replying questions from reviewers, or when we are reviewing papers as a reviewer. So Andrew Althouse has this great initiative of making a reference collection to push back against common statistical myths. Other statisticians stepped in and assisted in providing other references and other myths to be included. There's a wide range described in there on the website at the bottom. They describe things about p-values, covariate adjustment, post-hoc power, etc., etc. For each of those myths, there is a range of reference collections that are provided, as well as a brief rationale on the issue. So I highly recommend for you to check this website, and don't be frightened, because a lot of those papers, they are directed to non-statisticians, so they need to worry about fancy formulas and things like that. And even if you don't have access to the paper, at least being aware of what those common statistical myths are, I think that's very valuable. Also, guidelines are very helpful. And in the Equator Network website, you can have access to a wide range of guidelines, depending on the type of research that you are doing. So there are guidelines on randomizer trials, on meta-analysis, biomarker, observational studies, so on and so forth. So those guidelines are not just about statistics, but it's about reporting in general. So I highly recommend for you to check the specific guideline for your research question when you're writing a manuscript. As I mentioned in the previous slide, there are a lot of statistical myths, and obviously I can't cover them, all of them here in this webinar. So I selected 3 that I believe that are most common ones that at least I face with my job. The first one is about p-values trend. So frequently we see some papers in which the p-value did not meet the threshold for statistical significance, usually at 0.05, but there were small p-values, in which then the authors described as being a trend towards statistical significance. This is very common, and in this paper from JAMA Oncology and from 2018, they checked how often this occurred in the oncology literature, focusing on major oncology journals, and they found that 8.7% of original research articles in major oncology journals use at least one trend statement. I would expect that if we will do this for all oncology literature, that this will be higher. There are many different ways that you can describe without actually using the word trend, and this website at the bottom have at least more than 100 different ways that were gathered from peer-reviewed journals in which the authors describe a trend but not necessarily using the word trend. So they might say, as in the first example in here, trend bordering on statistical significance, But they also might say things like it was suggestive, but not quite significant, try to mean the same thing. But my favorite ones is flirting with conventional levels of significance, very closely brush the limits of statistical significance, and teetering on the brink of significance. And as you can see in here, the p-values actually doesn't matter that much when some of those authors are making those statements. In this paper, the authors did many simulations, and one of them was just to assess how often the p-value was non-significant when you add extra data, when you have a low p-value but not significant. So in this table that we have in here, I'll focus on this number to explain. So essentially here in the columns, we have the p-value at the time of the analysis. So let's suppose that the p-value was 0.08, and then here we added 50% extra data to that analysis. This means that in 40% of the time, the results were still non-significant, even after adding 50% more data. Okay, so just because you add more data doesn't mean that the results will be statistically significant. So what's the issue? The issue is that when we refer to trends, or when the authors write this trend, they are assuming that the p-value is moving while everything else is fixed and it's just the sample size that is increased. But that's not correct. What those sentences are trying to say is that there is a treatment effect or whatever you're testing, and they believe that that's true, that there is an effect, and that the reason for not being positive was the sample size, and not that there is no effect at all. In this simulation that I generated in here, I simulated response rate for two treatments, treatment A and B. Those simulations, I assumed that the response rate in each of the treatment arms was 50%. And then here we see what is the response rate as increase the sample size in this simulation. So let's say that it was designed for to do analysis after you have 60 patients in each of the arms. So in here, which is about 40% in treatment B and like 58% in treatment A. And the p-value for that is low, but not significant. So that's a common situation in which some authors will describe as being a trend towards statistical significance. But as you can see in here, the actual response rate is not fixed. It's not because we observe 40% at this time point means it will be 40% throughout, just increasing the sample size. As you can see, the jiggles goes maybe up, maybe go down. As you can see in here from the p-value. So increase the sample size and the p-value, and the p-value doesn't necessarily go down. It might go up, might go down, and keep varying like that. So having a low p-value doesn't mean that by increasing the sample size, you'll have a significant p-value. The second issue that I'll discuss with you, so the second myth, is about using screening covariates to include in multivariable models. So it's common that we see people doing chi-square tests, t-tests, so on and so forth, to then select variables based on a specific criteria, say with a p-value less than 0.05, or use a new variable regression to then select the variables to be included in a multivariable model. Let's look in this example in here. So I'm just referring as variable A, B, and C, so you don't use your clinical judgment to select the variables because this process is just based on the p-values that I'm using here. That's why I also not provide the hazard ratios. So if we'll try to apply this, and in this case, we are running with a model with just A, so this result that we have in the first line in here is when we have just A as the independent variable in the model. So in this case, it was not significant, the same when we have just B and just C. So if you do it like that, we wouldn't select A or B for the multivariable model, but we will select C because that was the only one that was statistically significant. However, let's assume that this was, the outcome was overall survival. Let's say that this was oropharyngeal cancer, and then the variables were actually age, HPV, and the zodiac sign as Aquarius. So if you ignore the p-values for a moment, then you might say, well, hang on, I think we actually should be adjusting maybe for age and HPV status, not for the zodiac sign. So in this silly example in here. So maybe one of the things that could be happening is that patients who are HPV positive, which maybe we expect to have better prognostic, maybe they were older, so then therefore then the curve might go down a little bit closer to HPV negative patients, and therefore that's why it was not significant. That's just one possibility. So in this paper, the authors did many simulations, and they also assessed with some real data this issue, and I selected one of the examples to show it to you. So in this example, they are assessing the relationship between sex and coronary artery disease. So this is just a cross-tabulation between the two, and as we can see, the p-value was not significant. And this is when we are looking at a logistic regression, when we're looking at each variable added independently. So just sex as independent variable in the model, we have this odds ratio and this p-value. If we have just physical activity in the model, then we have this odds ratio and this p-value. So if we use that rule of screening based on this, we'll select physical activity for the model, but not sex. However, if we look into more details and we look at the results stratified by physical activity, so this we are looking at sex and coronary artery disease in patients who are inactive, we can see that there is an association between the two. And the same if we look at for active patients. And if we do a regression including both variables in the model, then we can see in here that sex is significant in that multivariable model. So just because a variable is not significant in univariable model doesn't mean that it will not be significant in a multivariable model. So you might be inappropriately selecting the variables, have a wrong model at the end if you use this method. And the last issue that I want to discuss with you is about inappropriately splitting continued variables into categorical ones. So what that means is when you have a numeric variable, a quantitative variable, and you create groups. So common reasons to justify doing it is because it simplifies the analysis, it's easier to interpret, and it mimics clinical practice. Those are the usual justifications. However, there are a lot of drawbacks, a lot of consequences. The first one is because you are ignoring the actual value itself and just considering the group that they are in. So you're losing information. And when you're losing information, you're losing power. Sometimes can increase the probability of false positive results, can underestimate the variation of outcome between groups, does not represent the true relationship between the variable and the outcome. The choice of cutoff is generally arbitrary, and if you use the median, then you frequently can't compare studies because they'll have different medians. The mean p-value rule is used, the chance of spurious finding increases, and also there is incomplete correction for confounding factors. This has been discussed many times in the literature. There are many papers around these issues. Some of those papers might be spoiling the conclusions and including, already in the title, that is a bad idea. Just in case you don't have access to the paper itself, they're already saying very upfront for you to not do it. But this is still a very common issue that we see. Now let's look at one example in here. So let's suppose that we have an outcome as overall survival. And the variables of interest is to compare immunotherapy with immunotherapy plus radiation. And say that we want to, in the model, we want to adjust by stage, by age, dichotomized at 65 years old, and ECOG. So if we fit a model like this, what does imply, what the model is saying directly? Well, it's saying that someone who is 40 years old and someone who is 64 years old, they have exactly the same risk in the model. Someone with 65 years old and someone with 95 years old, they also have the same risk. However, someone who is 65 years old have higher risk than someone who is 64. Moreover, let's assume that 60% of the patients in the immunotherapy arm were in the elderly group, and exactly the same in the immunotherapy plus anti arm. And you adjust it for age in the model, as a dichotomous variable. So if you do that, you might think, well, all is good. I adjusted by age. So I will conclude that the effect or lack of effect of immunotherapy or versus immunotherapy plus radiation is independent of age, and all is well. However, let's suppose that of the elderly patients in the immunotherapy arm, maybe most of the patients were between 65 and 75. And maybe in the patients that are in the immunotherapy plus radiation arm, maybe mostly are between 80 and 90 years old. So despite that you adjusted by age as a dichotomous variable, you might still have a lot of confounding in here. And this will be affecting your estimates, and you might have wrong conclusions and wrong estimates because of inappropriate adjustment for the variable age. Like in this comic strip from Dilbert, with dichotomization, just because you can do it doesn't mean you should do it. Thank you.
Thank you very much, Matthias. As somebody who's over 65, I very much appreciate this dichotomization. Just to remind everybody, if you have questions for Matthias, please put them in the questions tab in your control panel to the right of your screen. Our next speaker is Mr. Joseph Descavia. Joseph's also a statistical reviewer for JMIRO, and I'd like to thank both him and Matthias for the work that they put in helping to improve the papers that we publish. Joseph has been a biostatistician at the Ingham Institute for Applied Medical Research since 2011. He routinely collaborates with research groups at the Institute, including radiation oncology, psycho-oncology, orthopedics, infant and child, and adolescent psychiatry. His research interests are in developing computational methods for statistical models in survival analysis. Thank you, Joseph.
All right, thank you, Michael. Yeah, so as you mentioned, my name is Joseph. I've been a biostatistician since 2008, and 10 of those years have been with the Ingham Institute. And as the title suggests, today I'll be talking about what statistical reviewers hate and like. And with my great creativity, I've highlighted things in red for things that I hate and things I like to see in green. So a statistical review. Now, when I'm reading a paper for a statistical review, there are generally a few things sort of floating in the back of my mind. And I'm looking for specific bits and pieces of information that allow me to answer one of these two questions. And if I feel that I can't do either one adequately, then I'll probably ask the authors to provide the missing information. Now, that being said, as a whole, I would say the majority of information is usually there at the first draft. And when I do make a comment, I'm usually asking for the last 10 to 20% of information that I need. And so many times my comments are either just clarifying things or restating things that's already been said, but sometimes in a more precise way. Now, this is of course assuming that I generally agree with the approach of the statistics. And if I don't agree at all, then you get a completely different set of comments from what I'll be talking about today. And so this talk will assume that we generally, or the statistical methods I generally agree with in your paper. And so the general structure of this talk will follow the typical order of a paper. As you can see, the statistics kind of basically covers every area. And so how you perform analysis actually affects all parts of your paper. The exception, of course, is I've placed the abstract last, since this is basically just a summary of the rest of the topics preceding it. And also I have the least to say about it. The examples I use today will come from relatively simple designs, like a two-group comparison, for example. And so anything I mention that applies to these simpler studies, there's probably an equivalent in your more complex study. And if you're unsure what that might be, then I would consider consulting your local friendly statistician. So we'll start from the beginning. So in your aims, hypothesis, or objectives, somewhere between these three things, I'm looking for very specific some quantitative and directional information. And so the first thing I actually look for is, have you specified whether the purpose of your study is to prove that there is a difference between groups of patients or before and after study, or are you trying to show that some outcome is similar or equivalent between two groups. And I know this might sound like a very trivial thing, but it actually has some implications for the sample size, for the statistical analysis, and how you interpret your results. And I'll show a very quick example of equivalence in a few slides. The next thing is, have you specified a direction of any change you want to observe? So do you want to see an increase, decrease, reduction? And finally, I'm also looking to see whether or not you've mentioned a degree or of clinical significance, or for equivalence, whether you've specified bounds of equivalence. So here are just some examples on the left. Sorry, on the left are sort of statements that you might see towards the end of your introduction, maybe in the last paragraph before you move on to your methods. And it basically summarizes what you're trying to do in the study. And so the first example is that we want to show an association between radiotherapy groups and survival. What I would like to see sort of, I guess, early on in the methods or somewhere where you list your objectives, I kind of want to see the same statement, but with a quantitative and directional information alongside with it. And so in the first example, I would actually say that we want to show an improvement in survival of at least 10% at 2 years in the radiotherapy group compared to the non-radiotherapy group. And you can sort of see equivalent examples of that in the further examples. The next thing I look for is some sort of sample size and power calculation. And the reason that this matters is because if in your study, your results don't show any significance, let's say with a p-value less than 0.05, I have no way of knowing whether or not you were just underpowered to begin with, or whether there truly is no difference or no association. And so it actually becomes a little bit difficult to interpret what a non-significant p-value is without some sort of sample size of power estimate before it. When describing your sample size, as before, you provide all the parameters that were involved in the calculation to the extent that someone else can take those values and they can plug it into their calculator and hopefully come to the same number as you. And so for this two-group comparison, as an example, I've listed the parameters that you need to see. Again, for other study designs, there are going to be different, there might be more, there might be less parameters. And if you're not sure, then again, consult your local statistician. So here are some examples of the typical wording. These are just made up. I haven't taken these from anywhere. You'll see in the first example that we need close to 7,000 patients in that group to find a hazard ratio of 1.1, which is equivalent to a 10% improvement. Sorry, 10% worse survival in the non-radiotherapy groups. I've stated the overall rate of death in the expected overall rate of death in the cohort, statistical power, and statistical significance. And so anyone should be able to take these values that are bolded and plug it into various calculators. From most statistical packages can do them, and even some online calculators. If you do find that there's variation between sample sizes that are sort of very few, I wouldn't be too concerned about that, because different programs kind of treat rounding rules slightly differently. So some will say, some will treat a rounding rule with the normal mathematical, you can round up or round down, and others will treat the rounding rule to always round up, to be a bit more conservative and be on the safe side. So these are two examples of where the study design is simple enough that you can just plug in values into a calculator, which then feeds into a formula, and it gives you a specific number. In some instances, in a more complex design, such as let's say you're doing a 3-level, multi-level model with longitudinal follow-up, for example, I don't believe there exists a number where you can, a formula or a calculator where you can nicely plug in some values. What you probably have to do is some sort of simulation study. And the idea of the simulation study is that you sort of guesstimate what your data, you sort of guesstimate what your data might look like. You generate 1,000 versions of that. And then of those 1,000 versions, how many times do you actually find statistical significance? And that gives you your statistical power. And so this might be a necessary step if you're, if you don't have a nice neat formula that can give you your sample size. The final thing I'll say about sample size is there are some rules of thumb sort of floating around. The most popular one is the 10:1 ratio of patients to variables in a logistic regression. I think this has been debunked a few times, but I'm generally not a fan of these. Like I wouldn't put these alone, mainly because it doesn't really address the issue of to what ability do you have your study to find some sort of clinical significance. A lot of these rules were made, which basically says how well can your sample estimate, let's say, an odds ratio from a logistic regression in an unbiased way. And that's all it does. It doesn't tell you anything about clinical significance. So if I do see this, I'll probably still ask for some sort of sample size based on some sort of clinical significance level. One thing I want to highlight is the equivalence. So you've seen this a few times already. The main thing that I've seen done is a non-significant p-value doesn't necessarily imply that things are similar or equivalent. And so there's usually a different set of criteria and tests that are required for this. And it does matter because it does have implications for your sample size and how you interpret certain statistics. The main thing is in an equivalent study is that you need to nominate the degree to which things are actually equivalent to. The same way that you would nominate how things would be clinically different in a different study, you sort of do the equivalent, you do the same thing for an equivalent study. And so again, for a two-group comparison where you're trying to show two groups of people have similar measures, there is something called a two one-sided test, or TOST. And actually what people advocate for is that you calculate a 90% confidence interval. And if that confidence interval stays within your bounds of equivalence, then you have statistical evidence that these two groups are in fact equal. One package really available in R is called TOSTER if you wanted to have more of a read. So here's one very simple example. I've just made this up. You've run your study and you've run some basic statistics. You have n sample size of 100 in each group. The mean in group 1 was 5 with a standard deviation of 1, and in group 2 the mean was 4.9 with a standard deviation of 1. So you can kind of see from the eye test they're probably going to be equivalent. Now what most people tend to do, and what I tend to see the most, is you calculate the statistic from a two-sample t-test and you end up with this p-value of 0.4803. And then you then conclude, therefore, these things are equivalent, p equals 0.4. What I would prefer to do actually is to do the two one-sided test. And with the two one-sided test is you actually nominate bounds of equivalence. So in this instance, I'm going to nominate 0.5 to be my bounds of equivalence. And the difference now is you actually get a p-value which is actually significant. But also in your conclusion, you can actually state that these two groups are now equivalent to within 0.5 units with a p-value of 0.0026. I do sometimes find it odd to read something, therefore, like statements on the left, where you have, therefore, these two things are equivalent with a non-significant p-value. And so it sort of feels a bit more natural, I guess, to sort of read the interpretation on the right. And as you can see, I've also calculated the 90% confidence interval for a difference. And you can see that this interval stays within the boundaries of my equivalence bounds of -0.5 to 0.5. And you can also conclude from that that these two groups are equivalent. The next thing is about how you go about describing your variables. Most people tend to do this pretty well. So just make sure you specify explicitly what your outcomes or dependent variables are, mention what your predictors and your independent variables are. If you are running some sort of repeated measures or which are correlated within patients, or you have patients within hospitals that are clustered in some way, I would mention the level of clustering. With the data types, sometimes it's obvious what data type just by reading just by what it is. So for example, if I talk about country of birth, I know that's going to be nominal, so you don't have to explicitly say it. I'd probably specify a data type when it can be more than one thing. And so for example, something like length of stay is, depending on the cohort you're looking at, that can be considered both continuous and count. And I would probably say, I'd probably say somewhere in the manuscript whether you have treated it as a count or as a continuous variable in the analysis. And Matthias touched on this, is that, yeah, I prefer to keep continuous variables as continuous unless there is some sort of strong evidence or some guideline way of cutting them. And probably the most important thing is to keep your data types consistent throughout the manuscript. So if you do choose to categorize a continuous variable, I would keep it continuous for the whole paper. I wouldn't try and change from continuous to categorical or vice versa from one analysis to another, mainly because they don't always conform, and it becomes very difficult to explain when you have two conflicting sets of results. In the statistical analysis section of the methods, I would mention the statistical model used for all outcomes, so both primary and secondary. I would also mention all the subgroup analysis that's planned. And the reason for this is sometimes I see sort of subgroup analysis being mentioned in the results section, and sometimes it can come across as looking like significance hunting. And so if you mention all the subgroup analysis that you plan on doing, then it looks like it's been done a priori. I would describe your model selection process, so how you get from the univariate to your initial multivariable model to your final multivariable model. So whether you use backward selection, forward selection, DAGs, or whether you based it completely on literature, just mention how you've done it. And depending on the type of modeling, there's usually a set of assumptions that you need to test, and I would also just mention how you've done that. So here's an example. I won't go through each one. I just want to highlight that if you've managed to describe your whole statistical model in one or even two sentences, you're probably not saying enough, and you should probably add sort of enough detail so that I can read this, and if I were to take your final working data set and read this paragraph, I should be able to come to the results that that you have presented in the paper. Software, mention all software that you used in the statistical analysis. And so if you've used multiple software, that's fine, just mention all of them. Each of them will have a recommendation on how to cite them. So in SAS, they want you to put it in the text, and you simply, I literally copy and paste this from the website and just change these versions and whatnot in the different places. In R, I like to say that what package I've used. So you can just put the main package, you don't have to put all the dependencies, and then you make reference to it in your reference list. And I'm sure most other major packages have their own way, which you can probably find either on their website or somewhere even within the package itself. Results, I think the results will be, other presenters will talk more thoroughly about these, but my sort of general set of things I look for is include a flowchart, and this is especially important if you've had to apply a large number of exclusion criteria. Of course, you describe the characteristics of your cohort using descriptive stats. If your data is missing, you want to do some sort of test to see what the characteristics are, maybe demographic characteristics are of patients with and without complete information. When reporting results relating to primary and secondary aims, I like to preserve the order that you mentioned them in sort of your aims, objectives, and your method section, so keep that the same. This is my personal bias. I like to include both univariate and multivariable analysis because changes in coefficients, they actually tell you part of the story. So if something was significant in a variate analysis and it disappears in multivariable, you know, there's some sort of confounding occurring, and that actually forms part of your story. When reporting your results in text, I like to include the statistics, so the odds ratio, hazard ratios, and along with their confidence intervals and p-values. So any analysis or test that you have done should be mentioned in the methods. And for p-values, I like to state the actual p-value, not some range, unless it's very, very small. So for example, p less than 0.001 is usually okay for most journals. With a discussion, basically no new results. So yeah, anything you discuss, it should have already been mentioned in your results. There are some words that have some technical meanings behind it, and so I only like to use it in that context. And so I might point that out if you do use words like significance or similar equivalent that's outside the context of their statistical meanings. And the final thing I'll say is that when you talk about statistical significance, I always encourage people to pair it up with some sort of clinical significance, because on its own, statistical significance may not be that meaningful. Finally, I would encourage you to use your appendix or supplementary data to provide details of the statistics that may not have been appropriate for the main body of the text. If, for example, you've done a simulation for your sample size, often what you tend to do is you test how robust your estimates are. And so you might want to include the details of that as part of your supplementary data. The abstract, anything I'll say is that if in the results part of an abstract, you've quoted a statistic like a hazard ratio, I do want to see the words like Cox regression or Cox proportional hazard models in the methods of the abstracts, and similarly for odds ratios in logistic regression or for any other statistical technique. And finally, I just want to state this. I think I've commented on this on pretty much all the reviews I've done for the last few years. Multivariate means you have multiple outcomes in a single statistical model, and multivariable means you have multiple predictors in a single statistical model. Thank you.
Just a reminder to everyone to put questions in the question section of the control panel for our Q&A session after the next, which will start after the next talk. So the next talk is by Dr. Emma Link. Dr. Link is a senior statistician at Peter MacCallum Centre. Her expertise is in design and analysis of clinical trials and research projects. She completed her doctorate of philosophy at the University of Oxford and worked on the medical statistics in genomic cardiovascular settings, and then came to Melbourne 14 years ago and switched to oncology. Dr. Link is going to talk on graphs and tables and plots. When do we use them and how? And I hope she's going to include a few tips on what not to use. Thank you, Emma.
Thank you, everybody. I'll just turn on my camera and get back here. Okay, thanks very much. So graphs, tables, plots. How do you work out what to do with them? So basically, this is a communication tool that you can use to determine how to get what you know into the minds of other people. So if we've got a graph, we've got a variety of different ways we can transform the data and put it onto the page or into an animation. But basically here we'll talk about things that can go onto the page. And so it might be appropriate to adopt one of the graphs listed here, or indeed perhaps something else entirely. Similarly with tables, there are many different ways that tables can be used to represent your data. And I've just listed here a handful of potential tables that could form part of the manuscript that you're wanting to present. to other people. Now, one way to do this, I've chosen to take a look at one of the articles that was published in JMIRO recently. So this is one particular article that was presented, and it's dealing with radionecrosis and therapeutic outcomes in patients treated with some radiosurgery. And I won't go through all of the details, but you can see here in the abstract, we do have a nice list of some of the statistical methods included and some of the results presented here in a number of sentences. Now, I've chosen here to pull out Table 1 and Table 2 for you. So Table 1 has a nice clear title, and it's used to explain something from the article that is needed to understand how we're talking about our particular outcome. So in this instance, it's the radiological diagnosis of enlarging contrast enhancing lesions. And then Table 2 is the perhaps conventional description of the patients that have been included in this study. So there was 152 of them, that's very clear. And we can see here that we have a number of characteristics for these patients. Some of them are continuous characteristics, like the age that the patients were treated in the study. And we're presenting this continuous variable with a mean and a standard deviation to capture how wide the age distribution is. We've also got the median and range and an IQR, which is an interquartile range. So this is in contrast to the statistics that you present in a table to summarise a categorical variable like sex and the other variables presented here in this table. So for a categorical variable, it might be appropriate to show the number of patients and the percentage of your whole sample this way. So some nice information when you're planning a table to communicate to other people. Provide your table with a clear, informative title. It's your aim when you're presenting tables and figures in your paper that they can stand alone, that you don't need to go into the text to glance at the table and understand the details that are being provided to you there. The column headings within your table need to be useful and complete. So in this example, we have the patient characteristics listed here. It's clearly telling you these are things about the patients, and we have our statistics provided here among the 152 patients. So the content is explained often in perhaps the first draft. You might just have the age and you might have the number, but we actually need to know, is the number the mean or the median? And similarly, is this other number a standard deviation, or could it actually be a standard error of the mean and another guy's? Similarly, is this range a range, or could you be presenting the interquartile range at this point in the table? It needs to be clear. One particular bugbear for some people is that the number of decimal places is sensible. We could calculate this mean of the age of treatment to 6 decimal places, but it doesn't become meaningful. So choose what is interesting and follow any of the guidelines that are specified by the journal regarding these practices. The tables are in your manuscript as a feature. We have a limited number of tables and figures quite often in manuscripts. And so make sure that they are there to provide useful information that doesn't need to be recreated in the text as well. It's appropriate to refer to the table within the text and potentially mention characteristics such as the age and the sex of the patients, but then you can reference the table to provide the additional information for readers. And similarly, you can provide pointing towards a table or a figure in an appendix or supplementary material. One other very useful point to consider is that all of your abbreviations are explained. So if for example, in this first table, if this E cells was just mentioned there without an explanation, it may not be understood by all of the readers in the manuscript. So looking at some ways that you can present your data, in some ways it might be useful to present it as a table, or it may be useful to present it as a figure. But we need to consider very carefully about what the message is and how easy it is to determine the take-home message. So this is an example where I've just taken these proportions of patients, or number of patients who have different primary malignancies in this particular study. So from our table, we've got very clearly the numbers of patients and the percentages, but we can convert that into a 3D pie chart over here, which is the same information, but I think that everybody will agree that this does not give us the same level of information that we would like to see. It's quite challenging to determine how much bigger this purple slice of the pie is compared to this pink slice. You have to look back at the key, the legend over here, and it's very difficult with a white bar. So obviously, you know, this is a very bad example of a graph, but in many instances, a 3D pie chart or donut won't be very clear at giving you the same picture. Similarly, the same information is presented in this bar chart, which has been turned on its side. Now, turning a bar chart on its side can be handy to present some sorts of information, and the categories here on the, well, y-axis can be shown a little more clearly compared to if it were a bar chart where this was the x-axis if it was turned on its side. And here you can see a little more clearly that the lung, non-small, long, small cell cancers are the largest patient group. But we have lost the information about how many patients, rather than the percentage, are actually included in this bar chart that's on its side. So it's very useful to consider in which instances you need the graphical representation with the pictorial facet compared to the actual specific numbers involved. If you need to label your graph with the specific numbers, it can get harder to interpret. So looking back at our radionecrosis example from the journal article, this was figure 2 in the article. Figure 1 was actually a patient flow chart to identify which patients were able to participate in the study. And then figure 2 is the main result of the study, which is a Kaplan-Meier plot of the cumulative incidence of radionecrosis. So just taking note of this graph, we've got a clear title, which is one of the recommendations for your graphs. And there's a clear X and Y axis label. So this is our X axis here. We've got our numbers equally spaced as the scale. And we have a label which is clearly indicating that the time scale is in months and stating that day 1 was the day of the radiosurgery treatment. We have our y-axis up here, which is the cumulative incidence of our radiation necrosis. We can see all of the data points here, and that's another important point to consider when you're doing your graph. So if we have a scatter plot, for instance, and we had information that was concentrated down this left-hand side of the plot, if we had all of our values here up to 20 months and then maybe just 1 point or so over here, it might make sense to enlarge this part of the graph. Or equivalently, if there was nothing out here, it would definitely make sense to restrict the axis limits to something important for the study and what the data is showing. We have consistent measurement scale here, so we're going up in equal amounts. We don't suddenly stop here and put in a zigzag and say, oh, well, we've actually, missed out a whole lot of information and changed scale. So here we've got 10-month increments and then we move on to 50-month increments out here. That doesn't, make sense or help with interpretation of the data that's being shown. And in some instances, grid lines may be useful, particularly if readers are going to be making comments or reading off the graph. Now, this particular figure has got a table element to the graph, so that if we're reading off the values for the cumulative incidence at these particular time points, the information is provided here with the appropriate number of decimal places to be sensible and confidence intervals for the primary quantity of interest. The uncertainty is shown here with the shading so that you can clearly see we've got more precise estimates earlier on for the earlier time points as we have more patients contributing to these estimates and fewer patients out of these later time points, as we can also see from the number at risk here. Some other points to think about when we're preparing graphs, to consider using simple colours that help with the interpretation. So you obviously don't use yellow or light colours on a light background, and have some distinction between curves of different colours. But be careful if you're doing red and green, if you know that you may have people that can't differentiate those particular colours and nanometers. Typically, avoiding 3D or distortion or decoration or shading is a good idea. Those things don't typically aid your interpretation of many of the pieces of information you're attempting to communicate. And a special point for Kaplan-Meier plots or incident plots are to include some measure of this number at risk, so it is explicitly clear how many patients are informing the early part of your curve and how many patients are informing the later part of the curve. So here's another example of a Kaplan-Meier plot. We have two groups here, and we're actually looking at following them up in a trial where they've been randomized. But this figure is showing some patients who didn't have metastatic disease at baseline, but some did have nodal disease. And we are looking at how many of these patients were free from a series of other events that were being monitored during follow-up. So we have initially 220 patients who did not have nodal disease and 31 patients who had nodal disease. And we've observed them going forwards for up to 4 years. And you can see ultimately that the patients with nodal disease are experiencing a greater number of events. A greater proportion of them are experiencing events than the patients that do not have nodal disease. We've incorporated a table within our graph here to show the proportion of patients who are event-free at each of these time points. So another type of result that's often of use to put into a manuscript or communicate to your peers or others is an effect size table or graph. So in the radiation necrosis paper, there was this example as table 5 in their report. So they've done a univariable Cox regression and looking at different factors which might be associated with radiation necrosis in their study. So what's good here is we know the sort of statistical test they did. We've got a list of the different risk factors that they tested in these single variable models. We have the hazard ratio with a degree of uncertainty presented and a reasonable number of decimal places, and then a p-value only to 2 decimal places. We could also choose to show effect with different figures. So this is just an example from another type of study. So this plot on the right is actually called a forest plot. And so in this instance, we have our main result of the study is actually looking at this odds ratio for an outcome among all of the patients that were studied. But then in this particular example, we have the same association tested in patients of different subgroups. So we have the younger patients here in this group and the older patients in this group. And so in a forest plot among subgroups, you're typically testing to see, or your graph is providing you with a visual assessment as to whether the association is similar among patients in different subgroups. So you can see in this example, the subgroups are all in line with the overall result, and indeed statistical tests were able to indicate that was the case. And we've got a situation here where we have additional text information in a table format shown alongside our figure here, visual cue, and then other numerical values to assist with the understanding of what went on in this particular research project. And here we have a cumulative incidence plot of the same, in the same study, where we've actually got our 3 groups of patients here, and we're looking at the incidence of the outcome of interest. So again, we've got clear x-axis, y-axis labels, and some additional information in a text above. So an additional plot that may be of interest in some instances could be this plot called a waterfall plot. Now in this particular example, we're looking at the change in tumour size. So we have tumours that are actually getting bigger compared to baseline on the left-hand side. And then the patients that are here on the right-hand side are actually patients who have had a reduction in their tumour size. And so these waterfall plots can be used to provide a graphical display of whether in that particular study patients were having a reduction or an increase in their tumour burden. This particular study has a number of different patient groups indicated here. And I'll leave it up to you to decide if it's successful or not with such a wide range of groups and colours. So it's always worth thinking about what is the message you wish to show, and does the plot enable you to communicate that sensibly. Another type of plot is that can be used particularly in genetic data settings that are used in manuscripts now and have been over the last 15, 20 years, are these Manhattan plots and QQ plots. Now, just in case you haven't seen a Manhattan plot before, it's this one at the base, where we have this particular plot has 300,000 single nucleotide polymorphism associations depicted here. So each dot is a SNP, and we're plotting the p-values on a negative log scale for an association with the outcome of interest. And so anything that's higher on this y-axis is indicating a greater association, a lower p-value. These plots are called Manhattan plots because often we have towers being built from these little SNP dots, and they can look like the skyline of Manhattan, a lot of skyscrapers. But in this particular example, we have one standout association, which is here, and that has been the point of a manuscript. This same data is presented here in a QQ plot without the chromosome information. So this is ranking the p-values generated, as shown here, and saying, well, look, if we were doing 300,000 tests, how many times would we expect to get a p-value of this level? And so it's saying we've got all of these 300,000 dots here corresponding to our polymorphisms. And if you've got a dot within this shaded area, that's what you would expect. But you can see there is a sole character up here. So this is further evidence that this p-value might be corresponding to a true association worth further investigations. We've got these 4 QQ plots on the side, which were actually just restricting the list of 300,000 SNPs to a subset. So it was genes that may have actually had some sort of biological plausibility. So you can see here we've got some SNPs that are outside the shaded area, and so they were worth following up in additional studies, depending on which subset of genes you looked at to begin with. So just as a summary, tables and plots can be an effective way to communicate methods and findings of your research to a wider audience. It's nice to work out a simple message that can be conveyed from the table or the picture, and take care and attention to communicate that message. There are many different sorts of graphs and tables, and so I've explained a small handful today, but there are plenty of others. And it's worth talking to a statistician about how to get your ideas across if you would like some assistance. And then if you are preparing plots and tables, then seek an opinion from somebody else that's external to your research to ensure that they are taking the message that you wish from your plots and tables before submitting the manuscript. Thank you.
If you have questions for Emma, could you please put them in the question list? And we're going to have a quick Q&A. We've got a couple of questions. I've got a few Dorothy Dixes. And if Matthias, could you put your camera on as well? Great. Okay, so we have one question from the audience, but before we start, I'd like to ask you a question. I must say that probably the most illuminating thing I've done is collaborating with statisticians. But I have a question: when should authors do their own statistics? When should they? Is there ever a time when it's simple enough to let them loose by themselves? I'll start with you, Matthias.
Okay, that's the dangers of that when they're doing statistics is knowing that what they're doing is correct. So it's not because the actual analysis that you might be performing in your statistical software might necessarily be complicated. So you might think that what you're doing is something that is simple, I can do it. But is the judgment whether that is the appropriate test that you chose or the appropriate model is the challenging part. So sometimes they might be potentially deceived or thinking this is just a simple test. But depending on some assumptions of the model, assumptions of the test, the distribution of your data, that may or may not be the correct approach for your analysis. So that's why it can be dangerous, because of they might not be necessarily able to tell whether in that situation whether that is actually correct to use that or not.
Okay, great. Joseph, have you got any other thoughts about when to? Well, I should ask you, if you should consult a statistician, when should you do it? For the post-mortem, as Fisher said, or at an earlier stage?
Yeah, well, I agree with basically what Matthias said. It can be difficult to know things like the assumptions of the test. I do encourage people that I consult with to have a go, only because if I think it's going to be simple enough, only because it kind of helps them, right, and to a certain level understand what's going on. And depending on what it is, I might fill in whatever gaps of knowledge they're missing and how enthusiastic they are about learning it.
All right, so there is a little enthusiasm for the do-it-yourself. So Emma,
But always consult the statistician.
Always talk to a statistician. So my question for you, Emma, is statisticians are a bit of a rare breed. I know in New South Wales, we had a special program to breed statisticians. We had a safe breeding program for them. They would be apprenticed under others and so on. But it's not easy for people in hospitals necessarily to meet a statistician, particularly as they're starting their project. Do you have any advice or suggestions?
Yes, it's a very tricky issue, and I was actually at a talk last week with Australia's chief statistician, who's head of the Bureau of Statistics, and I did say to him, I said, how do you get statisticians? How can we find them? And he said, well, we train them ourselves. We get them in early and we just go from there, which probably doesn't help with the question that you're asking. So the question is, how would somebody medical access a medical statistician to provide assistance with their research? And so the answer is there is a registry of statisticians now as part of the clinical trials group. So there are some ways that you can access a statistician or receive contact details for a statistician, and you can attempt to get into contact with them. But it really comes down to individual hospitals, I'm afraid, at this stage, and knowing a statistician and accessing a statistician to provide you with that early guidance. And it may not be a lot of assistance that's required, but if it comes at a crucial point, then it can minimise the need for more extensive help later. So it's a matter of using contacts within journals, within hospitals, to find a friendly statistician.
I would say that most senior researchers should know a statistician and have worked with them for quite a while, and they can also be a good entry point for a collaboration. I think people starting out in research should have look to have a mentor of an experienced researcher anyway, who can start to provide them a link through their network. It's an extremely important aspect of producing worthwhile research, not wasting your time and not ending up with a manuscript that bounces from journal to journal with lots and lots of questions. So we have a question from the audience, from Numan Kataiba. It's a general question on inter-reader agreement in radiology research. What is the minimum number of cases to assess out of a cohort of 100, for example? Should it be more if we are assessing an agreement on multiple measurements or observations in each case? So I think that means, do you need more cases if you've got more variables or more outcomes? Should be a fairly straightforward answer, I would have thought. Statisticians always want more, in my experience. Matthias?
Yeah, so we have, in this case, if I understand correctly, they want to know the number of patients that will be required for the analysis if they are doing inter-rater agreement. Is that correct?
Yes.
Yeah, so well, firstly, you need to first assess exactly what you are assessing. So what is actually the variable that you are assessing, whether they agree or not. So what type of variable is that, how many raters you have, and the variability of that. So all of that will affect to a certain degree of the number of patients that you need. So it's not just one number fits all kind of thing. So all of that should be taken into consideration when actually answering the question.
Okay, thank you very much. There are no other questions. So I'd like to thank our presenters who've covered a large range of difficult ground very well and quite clearly. I apologise that Dr. Tim Churches wasn't able to attend because he had an urgent personal matter that came up at the last minute. And his talk will be available with this whole webinar on the college website. Thank you very much for attending. And a final note on novel visualizations is JMIRO is going to sponsor one animation abstract or abstract animation per journal issue for the next year as a way of improving the access to journal and advertising some of the results. So if you have a particularly outstanding paper, we will be after you for an animation, and the college will pick up that cost. So once again, thank you to all of our presenters. Thank you to the college staff for supporting this webinar without a technical hitch, which is, I must say, quite surprising after our rehearsal. So it's gone extremely well. And I hope to see you back here next year for our next webinar. Goodbye.